Hello, everyone. My name is Yoav Keinan, and I'm an infectious diseases clinician and the scientific director of the National Collaborating Center for Infectious Diseases. I would like to welcome you to this webinar, Monkeypox, Perspectives from the US, which is hosted by NCCID in partnership with Public Health Agency of Canada and Association of Medical Microbiology and Infectious Diseases Canada. I would like to first acknowledge that we are located at the University of Manitoba on Treaty 1 territory on the original land of the Anishinaabe, Cree, Oji-Cree, Dakota, Dene people, and homeland of the Métis Nation. Let us acknowledge the harms of the past and dedicate ourselves to work towards reconciliation through collaboration with Indigenous communities. Just before we begin, a few housekeeping items. The chat tab will be used for communication with the attendees, so please check there. If you have any technical problems with Zoom, please send us a message using email provided in the chat box. The webinar is taking place in English with simultaneous French interpretation, which can be accessed in the interpretation tab at the bottom of your screen. There is an option to mute the original audio and listen to French only, if you so desire. The question period will be at the end of the presentations, and we will be taking place through the Q&A tab. Finally, a recording of the webinar will be available at nccid.ca, as will be available the previous recordings of webinars on the topic under the webcast tab, and it will be available shortly after the webinar. Now, I would like to introduce our speakers for today. First speaker, we have Dr. Erica Shenoy, who is an infectious disease physician at Mass General Hospital, where she is the medical director of the Emerging Special Pathogens Treatment Center. She's an associate chief of the MGH Infection Control Unit and an associate professor of medicine at Harvard Medical School. Our second speaker is Dr. Jacob Lazarus, who is an infectious disease physician scientist at Mass General Hospital, and his work on biothreats response team at MGH. Dr. Lazarus has informed patient care and contributed to the process improvement of research on emerging infections such as COVID-19 and human monkeypox infection. Thank you both for being here today with us. I will now turn my mic over to Erica Shenoy. Welcome, Dr. Shenoy.
Well, thank you, and thank you so much for having us. Can I get a thumbs up that you can hear me okay from someone? Everything sounding okay? Great. Okay, well, it's great to be here. Both myself and my colleague, Dr. Jake Lazarus, have worked on this presentation in two parts. So I'll start off with some of the epidemiology, give a kind of a personal perspective from Mass General Hospital where we are, but more of a US perspective, talk about infection prevention and control, and then I'll turn it over to Dr. Lazarus, who will talk a lot more about the clinical evaluation and treatment and do this through some case studies, some pretty interesting case studies of patients that we've taken care of here at Mass General. So this is the outline, and I'll start off with first our Boston, Canada connection, and then go through the items that I've described here. So this is Mass General Hospital. This building is from 1812. I'm actually talking to you from the third floor here where my office is, but lots has changed between that time and today, where we are a fairly large academic health center, about 1,035 beds, see thousands of patients each year, thousands of visitors each day in our facilities. If we roll back the clock to May 7th of this year, May 7th, this was when the United Kingdom had reported a case of monkeypox in a returning traveler. And as we all know, many of the cases that had been identified outside of endemic areas until this date were really travel related to one of the countries where monkeypox is endemic. But a week later, the UK reported 2 cases that were not connected to travel. And while this was all happening, we had actually had a patient admitted to our facility for a few days. They had been seen in outpatient setting a couple days before admission and then admitted on May 12th. Overnight from the 16th to the 17th, my colleague, Dr. Nestle Bascos, who's pictured here on the right, who was seeing the patient from infectious diseases, was really looking online to find out about anybody reporting anything like what she was seeing in this patient, which was a progression of a rash and with umbilication, vesicles, pustules that had really defied diagnosis. And she had done a very comprehensive workup at that point. And then she contacted me in the wee hours of the morning, having read about these couple cases in the UK that were not connected to travel. We obviously isolated, made sure the patient was isolated, contacted our local public health, and the CDC that day decided clearly to test the patient. We had a preliminary diagnosis that night of the 17th and then confirmed the following day. And this was the first recognized case of monkeypox in the US outbreak. And one thing I do want to mention, the theme we'll come back to later on related to infection prevention and control, is the concept of having an open mind, of trying to put together the signs, symptoms, and epidemiology of a patient to appropriately identify that they might have an important infection or communicable disease, isolate that patient, and then inform the right people. It's the identify, isolate, inform framework that is used a lot here in the United States, and I'm looking forward to hearing from the audience about ways that you all focus on this particular aspect of infection prevention and control. So I gave my colleague, Dr. Bascos, an A+ in the identify, isolate, inform. She was thinking outside the box about this patient and did the right thing in terms of getting in touch with infection control when she thought maybe this is going to be monkeypox. Now, the case is detailed in full in the New England Journal case that we wrote up. I just want to highlight a couple things about this. So the Canada connection is that this patient, Dr. Bascos, had been taking obviously a good travel history, and this patient had been in Canada, had what turned out to be exposures in Canada with male partners at the time, and there was no other recent travel. Further down, you can read that during the course of this workup over several days before monkeypox was on the differential, there was also additional history that was elicited in that this patient had been in contact with those individuals in Canada, and they had something similar to him that had also defied initial diagnosis, had not resolved with empiric treatment. And we had, Dr. Bascos had reached out proactively to public health authorities, asking our teams to reach out to Canada to see if there was some connection in this. And indeed, there was a connection. And this is from the news a couple days later, the day after we made the diagnosis, where this case was linked to a cluster of cases in Montreal. So partly what I'll go back to is in this first case, we obviously had a patient who had been not isolated for multiple days, and in fact had had multiple outpatient encounters and visits in many different health systems in the Boston area prior to monkeypox being on the differential. So a lot of our initial work in response to this related to, excuse me, identification of individuals who were potentially exposed, risk stratification, and counseling regarding post-exposure prophylaxis. So I'll get back to that at the end. So what is monkeypox looking like in the United States right now? If we take a big picture in the whole world, we're close to 60,000 cases. Obviously, the vast majority are in non-endemic countries, but many countries are affected, 103 countries, and there have been, as of yesterday, 22 deaths reported worldwide. Now, the epi curve from the WHO is looking favorable. It does appear that we have peaked, at least for this initial outbreak, and hopefully the initial is the last one, at least of this magnitude. But you can see the numbers as these are updated as of about a week ago. Now, in the United States, so here's the map of the United States, and it's somewhat of a heat map, so you can tell that it's not equally distributed across our country in terms of the burden of cases. And some of the initial cases that have had high volumes include New York, California, Texas, and Florida, along with Illinois. And Massachusetts is somewhere here in the middle, and our total count of cases of the total that are identified in the United States was actually about a third of the entire global cases, is about 350 in Massachusetts. So nowhere at the level of California, and the thousands in New York as well. And what about our epi curve? So these numbers are updated every Wednesday. So they're really at the end of today, we'll get more information on the US epi curve, but it does appear to be tracking along with the global curve and a few weeks behind Europe's epi curve. Now you might say, what was going on with this high bar here at the beginning of last week? We had a holiday on the Monday. So I think this is just a reporting delay, and that hopefully when the numbers come out later today, we'll see that the curve continues to decline. Obviously, there's no crystal ball here, but this is certainly a favorable direction. Now, what about testing? And this is a figure showing test positivity as well as number of tests. So test positivity peaked in the United States in mid-July. Now, testing, we weren't testing perhaps as many people as we should be testing at that time. Testing was limited in some ways, not so much in terms of the overall laboratory capacity, because we have many commercial labs and a very robust laboratory network among our public health labs, but I think more of this related to access, knowledge, and recognition of monkeypox on the differential as patients presented. But more recently, our positivity rate seems to have plateaued around 20% of those individuals testing positive. More on the epidemiology, and we'll be curious to hear Dr. Lazarus and myself about how this looks like in Canada. But the average age you can see is this young, middle-aged group. It is by far and wide men. We have seen a small number of women with infection, and the epidemiology appears to still be holding true with this is individuals who identify as men who have sex with men. In terms of race and ethnicity, initially in the early part of this, again, recognizing that testing was quite limited, it was primarily identified among white populations, but at this point, the majority of cases are being identified among Black or African American combined with Hispanic or Latino communities, and you can see that with the green and the magenta or purplish bar that's here. What about the symptoms that individuals are presenting with? So obviously rash, and that kind of makes sense because that's the only thing you can really test at this point. Our testing is only validated on actual rash or the lesions, but fever, lymphadenopathy, pruritus, headache, malaise, myalgia, and chills. We have seen actually case of conjunctivitis here, and there are some individuals who present only with or their primary symptom of proctitis. And this is based on a recent analysis published by the CDC. Now, what about this epi curve and why are we seeing a decrease? It's really too early to tell. This is a recent publication from the CDC looking at a survey conducted in the early weeks of August, asking individuals, specifically men who have sex with men, about any changes in behaviors that may put them at higher risk for exposure to and acquisition of monkeypox. And what they found is the reported decrease in number of sexual partners, in one-time sexual encounters, use of dating app or sex venue to identify partners, group sex, going to sex venues or events, and social events with close contact, such as dance parties or raves, and they saw an increase in the use of condoms in this population. Now, we're just going to switch gears and talk about transmission and infection prevention and control approaches adopted here in the US, and I suspect in Canada as well. So primarily, transmission is thought to be with close personal skin-to-skin contact, specifically contact with the rash scabs or the body fluids from an individual with monkeypox. Now, there is the possibility of fomite transmission, and this is something we've looked closely at, and I think this is something that has been reported, at least in prior cases, prior to this outbreak, specifically from vaccinated individuals with the live replicating vaccine, where there had been fomite transmission documented through towels between a vaccinated individual and another individual. But certainly the surfaces that become contaminated with fluids from lesion scabs, body fluids, can potentially be a source of transmission. Just because you detect virus in these locations doesn't mean that they are viable or that they will lead to an infection or a transmission event, but this is certainly an important focus of infection prevention and control. Less I guess how to say this, less thought to be a real risk of transmission would be the respiratory route. And this is thought, if it is occurring, to really require prolonged face-to-face encounters, not fleeting sorts of encounters or in any sort of proximity. Now, during pregnancy, it can be passed from the placenta from the mom to the fetus. And this hasn't been a part of this outbreak, of course, but from infected animals via scratch or bite or by contact with the products of those infected animals. And the infectious period is quite long. And so this is really, I think, a challenge for our patients having to isolate for such a long period of time. And it can take even more than 4 weeks in our own experience with some individuals with monkeypox infection. Dr. Lazarus is going to go into a lot of detail about the rash, and I only bring these pictures here to kind of drive home the point about the contact aspect of transmission, and that these are lesions that are, teeming with virus, and that's really the main mode of transmission at this time is thought through a contact with those lesions. Now, we think of, or at least how I teach infection prevention in many of my lectures, is around the cycle or the chain of transmission, and that these are the requirements for an infection to be transmitted from one individual to the next. There has to be a reservoir. In the case of human monkeypox, we're thinking about infected individuals, but also contaminated intermediaries, surfaces, towels, those sorts of things. It has to have a way to get out of that reservoir. So if an infected individual has a lesion, that lesion can then come in contact with another individual, have a portal of entry, either through a rent in the skin or some other portal of entry to a susceptible host. And for the most part, most individuals out there are susceptible because vaccination for smallpox ended a while ago. And few of us out there have either had infection with monkeypox or have been vaccinated. So there are many susceptible hosts out there who can then be infected. And obviously our interventions are aimed at all of these aspects of the transmission cycle in order to prevent transmission from happening either in home situations or in healthcare settings. Now, how have we focused our infection prevention and control? And the first part gets back to that initial description of our first case. And it's a process that's repeated every single day in our healthcare facilities for all sorts of infections, in which we want to make sure that we think as a clinician about the potential for an infection. Sometimes that will be informed by the travel or that an individual may have, the symptoms or the combination of symptoms they may have, and other relevant epidemiology, for example, exposure to particular animals. It can often have an official person under investigation or PUI definition. That's the way it's described here. So the CDC will publish a PUI definition and allows us to kind of structure an approach to thinking about, could this person be at risk? If they are, what are the next steps in terms of evaluation? Now, the isolate piece comes next, but it's very important that often these definitions or our suspicion has to be raised, even if the epidemiology doesn't quite fit. Or if there's a spectrum of presenting signs and symptoms. And if we think back to May, pretty much none of us had ever really looked at monkeypox before. Some of us may have had some experience dealing with this in the US back in the 2000s when there was a prairie dog outbreak, or in evaluating individuals traveling from endemic regions, or maybe some of us working in those areas. But for the most part, we did not appreciate the spectrum of signs and symptoms and the chronology of how those might present. And therefore, it's always important at the time of identification to have an open mind and to think about what this could be, even if things aren't quite exactly by definition or what you expect. Now, isolate is obviously applying the appropriate isolation immediately, and informing the right people. And this can be, as in the early days, talking to public health right away, but in routine and healthcare settings, you want to make sure that everyone taking care of that patient knows that now monkeypox or whatever pathogen you're concerned about is on the differential, so that they can apply the appropriate isolation and be aware of the workup that's ongoing. Now, there are a lot of tools out there related to identify, isolate, and inform. There are some that were developed very robustly during the 2014-2016 Ebola outbreak in West Africa. These have been adapted for Middle East respiratory syndrome, and there are some generic ones that can be used to really apply to any pathogen that you might be concerned about. Now, whether you go low tech, which might be pen and paper, posters, or more high tech by embedding this into the electronic health system or other alerts, it is incredibly important that it's really part of the clinician's workflow. Things are very busy in healthcare right now, and to the extent that you can make this really easy for clinicians to be aware and informed, that is really critically important. And so a lot of our work, and I'm sure a lot of the work of the people on this webinar, has been around educating clinicians about clinical recognition for a disease that they have had little or no experience with. And as we've learned more about the disease over the past few months, we're learning about different sorts of presentations. And so there is an importance of re-educating as we move forward. We're also educating our clinicians on what to do related to infection prevention and how to test. And many of those things have been in flux, which makes it pretty challenging to keep up to date from the frontline perspective. Now, we've used at our system embedded clinical decision support in the electronic health record. This is something that we started using really effectively during COVID, and have since tried to use it for many different things in infection prevention and control. And in the setting of shifting person under investigation guidelines, our infection control guidelines have changed over time. Our testing strategies have certainly changed. Having this updated in the background and presented to the clinician in the electronic health record has, for us, we think has been an effective strategy. And I'll just show you a screenshot of what this looks like right now. If someone shows up in our emergency room or calls into their primary care's office and the clinician is thinking this could be monkeypox, they go into the record and they type monkeypox, and what presents to them is the most current evaluation, person under investigation definition, instructions on what to do. And then it, based on the answers, it'll say, you know, monkeypox is on your differential, we agree. These are the next steps, ordering tests, where the patient can be evaluated, or no, we don't think this person meets criteria, but if you still have a suspicion, here is who you should talk to. And then it for patients who are identified as at risk, it labels their chart accordingly. So that informs other individuals in the institution when the patient is being managed that this patient is under evaluation for monkeypox. So that's a strategy that can be pursued. Now, it's very important to keep an open mind when evaluating patients. I've mentioned that before. This is a recent case of an individual who presented with 7 days of a vesicular rash. This is in California. They had no sexual contact. They had no identified epidemiology that would put monkeypox on the differential. And you can see that the only risk factors that were, again, elicited, and these wouldn't be risk factors that you would see in any definition of human monkeypox, but are attending a crowded outdoor event with close contact, and then sharing an e-cigarette. And this patient was eventually diagnosed with monkeypox. Now, on the other side of the coin is the concept of what happens when we test low probability individuals. Well, there is always the possibility of a false positive, and those false positives can be very consequential. And this is a recently published case series of 3 patients who had very low pretest probability and had false positive monkeypox PCR results. All 3 of the patients had atypical rashes and uncharacteristic risk factors with no epi link to a confirmed monkeypox case. Now, if we think about the impact, patient A was a pregnant woman. She delivered a newborn. And what happened, because monkeypox was considered in her, is that infection control precautions were applied, including no skin-to-skin contact with the mother and the newborn. There was delayed breastfeeding, disposal of the expressed milk, and the newborn actually received Vaccinia immune globulin. And the eventual diagnosis was bedbugs. Patient 2 was a school-age child. This child, because of the presumptive diagnosis of monkeypox, was treated with Techobiarymat. The patient was isolated at home, and PEP was administered for all of the family members and some other children. And the eventual diagnosis was enterovirus. Now, patient C was in fact an infant, and this involved a family trip with multiple families 12 adults and 7 children ended up receiving post-exposure prophylaxis, and multiple families had their travel plans affected for weeks because of all of this going on at the diagnosis. And actually at the publication, which is just a couple weeks ago, I think there was no final diagnosis for this child. Now, once the monkeypox has been put on the differential, patient placement, and I'm presenting the guidelines that are current right here, is in a single private standard room. Up until the end of May, the initial guidance had been the use of airborne infection isolation rooms or negative pressure rooms, but that has since been changed, and this is only if aerosol generating procedures are planned or anticipated for the patient. So we are using standard private rooms for these patients. In terms of personal protective equipment, for the patient, a surgical or medical mask is placed on them for source control. And for healthcare personnel, we're using gowns, gloves, and N95 respirator and eye protection. Now, we get lots of questions about the N95 respirator because this is not considered an airborne transmitted disease. And in fact, some jurisdictions in the United States recommend an N95 respirator only in the setting of aerosol generating procedures. So there's variation. There's the CDC guidance, and then state and local public health may have different recommendations. Now, PPE, obviously an incredibly important part of how we ensure that we protect healthcare personnel and also reduce the risk of cross-contamination to other and exposure of other patients, but it has to be worn correctly. This is a study from pre-COVID and pre-monkeypox, and I often reference it because it really brings home the concept of PPE can be incredibly effective, but it has to be used correctly. And that self-contamination and cross-contamination is certainly a risk. And this is a study where they did simulation. And at baseline, about half of individuals, these are real-life healthcare professionals, contaminate themselves. They contaminate their skin or their clothing, and you can see that with the black light. But you can teach people to do this correctly and to doff appropriately and reduce the risk of contamination. And those who use incorrect technique are much more likely to have self-contamination. Now, waste management was initially kind of a hot topic, and I think that rightly so. But during the current global outbreak, all cases are expected to be clade 2, formerly known as West African. It means that waste management is routine waste management. Had this been Central African or clade 1, waste would have been considered category A, which is a much more complicated thing to deal with. Now, standard cleaning and disinfection should be with approved hospital disinfectants. And it's really important, again, just like PPE has to be worn correctly and doffed correctly to follow directions for concentration, contact time, care, and handling. Now, a couple of things to focus on are portable medical equipment. For those of you who do infection prevention and control, you know that this is a challenge all the time to make sure that our portable medical equipment is cleaned and disinfected between patients. And then the built environment, of course, always a challenge in terms of making sure that it is also appropriately cleaned so that it is not a reservoir for our patients. Laundry should be handled according to standard practices, which means it's not shaken and it should be handled in a manner that will not disperse infectious material. In our facility as well, we've made sure that our exam room curtains and other linens are laundered after patients. And that, from a practical perspective, if you're seeing patients in clinic and you can just keep the linens out of the room, that can make turnover easier, and you'd avoid even having to launder them if they're not present. Now, contamination of the environment is clearly a concern. This is a recent study sampling various surfaces in a room occupied by patients with monkeypox. And they did a couple of things where they were looking for the virus, of course, and they were looking for viral load quantification as well to get a sense of the amount of virus in various locations in a patient room. So first take home is that all surfaces that were touched by the patient's hands had viral contamination, and the highest viral loads were detected in bathrooms. And I've just put a little box around the highest viral load areas there in the bathroom. Now, interestingly, there were areas in the room where the patient never would have touched, but would have been touched by the hands of healthcare personnel, and those also had detectable virus. Additionally, fabrics that were extensively used by the patients, their linens, showed viral contamination. And you can see this is how contaminations can spread through a hospital environment, is that the healthcare personnel using their gloved hands, touching those fabrics, those the gloves are then contaminated, and that was shown in this study as well. Doesn't mean that this is viable virus. That has been studied in other studies, but it does really show that the care of the environment, the surfaces in the environment, especially the high touch surfaces, are potential reservoirs and need to be attended to. Now, what about exposures in healthcare settings? So obviously, identify, isolate, inform is going to reduce, when done correctly, is going to reduce the opportunities for exposures. And then the use of our infection control protocols, clearly the personal protective equipment are protective. However, exposures do occur when there's a delay to identification of a patient as a monkeypox suspect. They can also occur if you have a healthcare personnel themselves who is infected with monkeypox, and that person is in the healthcare setting working while infectious. Now, as we were confronted with this first case, we undertook a review of the literature to understand prior to this outbreak how likely or what did we know about transmission in healthcare settings with monkeypox. And this was a very practical sort of review we did because we were in the process of counseling colleagues. We had over 100 healthcare personnel exposed at our institution alone about what the risk was. And part of that was our own education about what had been reported in the literature. And we looked at 2000 to right up until this current outbreak. And there's only one case of transmission from a patient to a healthcare worker. And this was in the setting of not utilizing appropriate PPE and in the setting of changing patient linens, again, highlighting the potential risk there of highly contaminated linens and other sorts of items that can be fomites. Now, during the 2022 outbreak, I've only heard reference to 2 healthcare worker infections that have been reported. There may be more that you all may be aware of. And one of them is described as a needle stick exposure. It's a preprint. I'll keep following that literature to see what we learn. But overall, I think the experience, at least of what's been published and what we know about, is that the risk in healthcare is low. Now, partially, I think because of this, the CDC recommendations for prophylaxis for healthcare personnel really don't recommend pre-exposure prophylaxis here, at least in the United States, for healthcare personnel with very limited exceptions, and they're listed here. Now, post-exposure prophylaxis is clearly indicated, and this is for high-risk exposures as defined by the CDC and on a case-by-case basis for a subset of intermediate risk exposures. Now, challenging is that it has to be administered within 0 to 4 days after exposure to have the maximal benefit to abort the possibility of infection, but it can be given up to 14 days. And we were really up against the clock in our initial case patient because the patient had already been in our healthcare setting for a good number of days before we identified them, and therefore the clock was ticking for making PEP available and identifying those who needed PEP. Now, the current CDC guidance around healthcare exposure risk assessment is listed here. I'll say that in practice, and I'm really curious to hear what the audience has in terms of working up some of these exposures, is that it is really hard to do an exposure investigation. Some of the implementation challenges have to do with a scheme that has to be able to classify a wide range of interactions between a source, the infected individual, and the exposed. It has to account for the exposed and the source to be different people. They could be patient or they could be healthcare worker, vice versa. You can have patient-to-patient exposures. You can have patient-to-visitor. And we have a lot of non-private rooms for patients. And therefore, if we have an infected individual that we identify in one of the beds, we know that there were healthcare workers coming to see the neighbor and visitors. You have to take all of that into account. Add to that the types of interactions that can lead to exposure, direct contact with the lesions or blood, body fluids, those sorts of things, indirect contact through intermediaries like a overbed table, linens, and a possibility of respiratory for close contact, all modified by the personal protective equipment that's worn by the source and the exposed. So it's incredibly complicated to try to risk stratify individuals on a case-by-case basis. It is an understatement. We've done multiples of these in various formulations, and it's really challenging to do. It takes a lot of effort and focus from infection prevention and occupational health and others. And it can be additionally challenged when the healthcare worker is the source, because these guidelines are really aimed at when the source is the patient. But when you have to flip it around, it can be quite challenging. Now, this is not meant to anybody to memorize or look at this, but this is the grid that we applied and developed off of the CDC initial guidance in our initial exposure. And the reason we did this is as we started talking to our healthcare workers, it was clear that we needed more specificity in order to bucket them into either high, intermediate, or low risk. And so we developed a grid in collaboration with our public health partners to try to be able to kind of clearly delineate, is this a contact or a respiratory exposure? What is the level based on PPE and the activities that were conducted? And the activities are really important because if you look at intermediate risk exposures, a lot of these intermediate risk exposures have to do with this indirect contact with linens or other contaminated materials. And it's really hard to go through that with a healthcare worker and say, do you remember touching this or that? And so it can be, again, quite challenging. So when we had to implement this back in May, we used some technology. So we used a survey system where we implemented all of those sorts of scenarios. We sent this to our possibly exposed healthcare personnel. They were able to select out what they thought applied to them in their situation. And based on that, had follow-up with a set of clinicians who were able to talk them through more of the details. We also enrolled them in an automated symptom monitoring program that could text message them or send them an email in order to do the monitoring during their exposure period. And then we offered post-exposure prophylaxis for a subset of individuals who met that high-risk exposure and for on a case-by-case basis for some of the intermediate risk exposed individuals. And that's where we used our literature review to try to help have those conversations and provide counseling to our colleagues. Now, since that time, we've done a lot of modifications to that grid. If it looked complicated to you there, we've simplified some aspects, we've downgraded some of these exposures, and we've also added really language that allows us to flip it if the source is the healthcare personnel versus if it's the patient. We've also included laboratorians in there because that's come up on occasion. And what we've done is we've modified that REDCap survey tool each time so that if we do have an exposure, we know that we're sending out to our healthcare personnel the most up-to-date scenarios for them to select from. And based on their selection, there's either no follow-up, there's symptom monitoring, or there's symptom monitoring plus some discussion about post-exposure prophylaxis. Now, just going to pause here as we close up and think about transmission in healthcare appears to be quite low if we do everything right, which we're trying to do with identify, isolate, inform, appropriate isolation, appropriate use of PPE. But it really does highlight the importance of this is, while we're in the middle of an outbreak, it's still a pretty rare diagnosis. And so it's incredibly important that hand hygiene and standard precautions be part of everyone's day-to-day work each time we see any patient, interact with any patient in our facilities. And this is brought home by a study that was done pre-COVID, pre-monkeypox, looking at the hands of healthcare workers. And they just had someone sitting outside of a surgical intensive care unit, just watching where the hands went. And these are all these gray lines are each time there was a touch between the patient who's at the center here and all the other aspects or high touch surfaces in the room. And you'll notice there are lots and lots of interactions here between things that are in the room, things that can become reservoirs for onward transmission. There is less activity around the hand sanitizing and gloves. And in fact, in this study, hand hygiene was performed only 1.2 times. And as we know, it's at least 2 because you went in the room and you came out of the room. So incredibly important to think about all the places where our hands go and how important hand hygiene is. And that's part of standard precautions. Now, when standard precautions goes wrong, it can go very wrong. And so here I'm choosing a case study from COVID, which is an outbreak of Candida auris in Florida, where the Florida Department of Public Health was alerted to 4 Candida auris infections in patients in a COVID-19 unit at a single hospital. In response to this, of course, because it's an unusual infection, they did a point prevalence survey and found about half of all patients were colonized with C. auris, and a subset of those had an infection or developed an infection. And what did they find when they did observations here? And what it is a total failure of standard precautions and the use of PPE in ways that it really shouldn't be used. So they found that healthcare personnel were wearing multiple layers of gowns and gloves caring for COVID-19 patients. They would do hand hygiene on gloved hands. No, we don't do that. And then really, when I see that sort of thing, I think of what healthcare personnel are probably internalizing, which is that the gloves are a substitute for hand hygiene. And that's not the case. Gloves become as contaminated as our hands, and hand hygiene is really just so critical. They also found that mobile equipment, reusable medical equipment, was going in and out of patient rooms and not being cleaned and disinfected. So there you have a reservoir that can lead to transmission events, and certainly that would be implicated there. And then the accessing of the clean supplies using contaminated PPE, specifically the gloved hands that were contaminated. Now, when they stopped all of this, the outbreak ended. And I just give this as a illustrative sort of story that when there are concerns about the potential for transmission, sometimes the reaction is to add more. And I think the take home is we use PPE appropriately, we make sure we're implementing standard precautions, and that can be incredibly effective at reducing the risk of transmission to healthcare personnel and to patients. So I'll summarize here and turn it over to my colleague. So the epi curve, excuse me, in the United States has started to decline or plateau. I think one interesting part will be, what does this mean for testing? We built up a testing infrastructure. There is a treatment available that Dr. Lazarus will talk about, and some of the studies that are ongoing there. And our vaccination strategies may shift as we are kind of coming down to this curve, and that'll be interesting to look at and think about. For transmission, correct, consistent implementations of standard precautions is absolutely essential. And then we add, based on transmission-based precautions as indicated. I think you can't underscore the importance of this identify, isolate, inform framework, because it really is what will prevent exposures from happening, and will also ensure that patients get early treatment, early evaluation, and that can improve their outcomes. I think the risk in healthcare appears to be low for monkeypox. These exposure investigations are very resource intensive. They're important to do. We learn a lot from them. And then lastly, I just want to thank Dr. Susie Hoda and Dr. Isaac Bogach. Dr. Bogach and I were fellows together, and I reached out to them to learn a little bit more about where to go to learn about monkeypox in Canada, and they were kind enough to send me in the right direction. I'll stop there and turn it over to Dr. Lazarus. Thank you.
Thank you very much for your presentation, Dr. Shenoy. Dr. Lazarus, the floor is yours, virtual floor.
Thank you. Thank you, and thanks, Dr. Shenoy. Thank you again for inviting us. So I'm an infectious disease doctor at MGH, as you all heard, and I've been involved in our monkeypox response here, including not just seeing patients, but also treating them with Techobiarymat. I've been involved with our vaccination efforts, and I'm also a co-investigator on a RCT of Techobiarymat that I'll tell you about. As you're all familiar with, monkeypox is caused by the monkeypox virus, which is similar to variola, which caused smallpox, but thankfully is now eliminated. It's also relatively close to vaccinia, which was used for the derivation of smallpox vaccines. Though vaccinia was long thought to be derived from cowpox, it turns out that the modern vaccinia strains are actually probably more closely related to horsepox and rabbitpox, which may be relevant for vaccinology. So we know that monkeypox is endemic in Central and West Africa, probably in a small rodent reservoir. And it was named monkeypox due to its initial identification in an outbreak of a monkey research colony. But there are efforts underway to rename it, since monkeys are not its natural reservoir. And though it's historically caused low-level disease in Central and West Africa, and cases outside of Africa were predominantly related to travel, this has obviously changed. In endemic regions, clade 1, so this is formerly known as Central African clade, has historically caused considerable mortality. Thankfully, clade 2, the one that we are dealing with, has historically had low, though not zero, mortality. So as Dr. Shenoy told you, the first outbreak was, the current outbreak was first detected in May. And initially it was thought that the epidemic could be the result of a single travel related case and subsequent super spreader event. However, it was known that even prior to this outbreak, there was human-to-human transmission in Nigeria at least as early as 2017. This was hypothesized to be due both to loss of population-level immunity to vaccinia and consequently to monkeypox, but probably also the result of urbanization. And tellingly, 80% of the recent pre-outbreak cases from Nigeria were, in contrast to the more earlier sporadic cases that were seen, which affected mostly children, these cases concentrated in adult men 21 to 40 years of age, which not coincidentally is the same group disproportionately affected in the current outbreak, and certainly implies at least ongoing low-level spread in Nigerian sexual networks. And additionally, as more genomic data are deposited from the current epidemic, not all the viruses are clustering together, though the vast majority seem to share genomic epidemiology very closely to the initial European cases. A smaller amount seem to have diverged earlier, suggesting at least low-level cryptic transmission outside of Africa. The authors that I refer to here date this to at least as early as mid-2021. You may have heard that preliminary analyses of the mutation rates have shown higher than expected rates based on what we know about other orthopox viruses. This can be a signature of ongoing human-to-human transmission, since many innate human viral defense mechanisms actually work to actively mutate viruses. And though mutations have been noted in a surface glycoprotein that's known to be immunogenic, it's unclear as of now if any of the mutations have resulted in any increased inherent transmissibility. So Dr. Shinoy spoke about the clinical presentation.
Sorry, doctor. Sorry, just a moment. Our interpreter is having trouble hearing you. Do you mind moving a bit closer to the mic, please?
Oh, of course. How is now?
Thank you so much.
Okay, all right. Hopefully you all can hear me now. So Dr. Shinoy spoke about the clinical presentation of monkeypox. Let me go into greater detail about the clinical evaluation that should be performed. So I'll talk about the core parts of the history and physical exam. Patients may have multiple complaints, and as usual, you should perform a history and physical appropriate for the overall clinical situation. And though it's tempting to anchor on monkeypox for a person with appropriate epidemiology, you should avoid that, even for patients that are presenting specifically for monkeypox evaluation. Key parts of the history include the timeline of the illness, when exactly the rash erupted, when, if applicable, the prodromal symptoms began, and of course, note the ways that patients describe their rash, its distribution, if there was any pain or itching, and to aid in the differential diagnosis, if the patient has had a previous rash in the past or suspects that the rash is due to another process. Early in the outbreak, when awareness of monkeypox was lower, we were seeing many cases of patients who presented after a presumptive STI diagnosis or a cellulitis diagnosis, and whose symptoms did not improve after empiric antibacterials. Epidemiology remains important. So elicit the number and gender of sexual partners in the past month, the date of the last sexual contact, the type of sex that occurred, and if there are any higher risk sexual behaviors that could predispose to monkeypox, for example, anonymous or semi-anonymous sex from online apps. You should also elicit if the patients participate in group sex or if they have sex while intoxicated. All of these practices likely increase the risk of monkeypox, just like they increase the risk of other STIs. Of course, also ask if they have a known monkeypox contact or contact with somebody with a similar appearing rash. In the past medical history, elicit conditions that might indicate a higher risk profile, such as a history of sexually transmitted infections. If a patient is on HIV pre-exposure prophylaxis or has HIV, as well as conditions that could predispose to severe monkeypox, including immunosuppression or atopic dermatitis. Importantly, though a significant minority of cases had HIV, we have not appreciated more severe disease in patients with well-controlled HIV, thankfully. So on the physical exam, note their vital signs to make sure there's no systemic toxicity, though this has been very rare in the absence of severe bacterial superinfection. A full examination of the conjunctiva and the oropharynx needs to be performed along with a lymph node exam, particularly focusing on the cervical and inguinal region. Ask patients to disrobe so you can perform a complete skin examination. Some patients will only have a single pustule, and it's incumbent on us to find it. They also need a complete genitourinary exam with careful attention paid to the penis, scrotum, perineum, and anal or perianal region or vagina if you have a female patient. A rectal examination for tenderness or bleeding should also be performed if there is suspicion for proctitis. Anoscopy has been performed in unusually severe cases or when there's suspicion for co-infection or an alternative diagnosis, but it's not part of our usual routine care for patients with anal or perianal complaints. So what sort of testing should you do in addition to monkeypox testing? Bacterial STIs have been detected in many early case series in up to 1/3 of patients. And I think that roughly bears out from what we've been seeing here at Mass General. So screening for these should be part of routine care. This includes gonorrhea and chlamydia at all sites where the patient has sex. Remember that patients may underreport or misremember the frequency of receptive anal sex, so err on the side of testing there. You also need to test for HIV, especially if patients are on pre-exposure prophylaxis. If there is concern for acute HIV, that is if there's a more disseminated rash or diffuse lymphadenopathy or systemic symptoms, especially if they've had sex in the prior 2 weeks, an HIV viral load should be sent. We have been making diagnoses, new diagnoses of HIV in the current outbreak, including at Mass General. And of course, patients who present for monkeypox evaluation are likely great candidates for HIV pre-exposure prophylaxis. So if they're not already on this, you should link them into care. So I'll briefly review the usual presentations of monkeypox before delving into important differential diagnoses and more in-depth cases from Mass General. So as you guys know by now, the monkeypox rash is polymorphic, which means that though there are lesions that are classic for monkeypox and are easy to identify, it has less typical appearances as well. And though the classic progression, as we've all been taught, is a macule to a vesicle to a pustule to ulceration and crusting, lesions may not need to proceed in this sort of orderly progression. Classically, monkeypox lesions have a small amount of surrounding erythema, though this may be much harder to appreciate in darker skinned individuals, or it may be completely absent. Lesions could be disseminated over large parts of the body, or they could be limited to a single body area like the anogenital region. Solitary lesions have been described as well, and we have seen these here at Mass General. And these may be particularly hard to recognize as monkeypox. So let me refer you to the slide. So in some patients, the lesions can be quite large. As you can see in A and B, there can be multiple lesions that involve the face. In C, there's only this subtle lesion at the angle of the mouth that could be very easily confused with an angular cheilitis from another etiology. E, F, and G highlight oropharyngeal lesions. In some cases that we've seen, the oropharyngeal lesions might just present as a very angry-looking red plaque that is often unilateral. This could be the result of the site of inoculation, and these are extremely painful. Monkeypox can also affect the eye, either causing discrete vesicles or a viral conjunctivitis, and in severe cases, a keratitis that can result in scarring. These cases have been blessedly very rare in the current outbreak. We have seen one case of conjunctivitis here at Mass General, though the patient is recovering and his vision has remained normal. And I'll illustrate this in some of our case studies. These lesions may result from auto-inoculation, that is, from patients spreading viral particles from the initial skin lesion to the eyes or to other body parts, which emphasizes both the importance of early case detection, as well as, once monkeypox diagnosed, proper hand hygiene and proper laundering of fomites, including bed linens. So the anal rectal lesions, they can be painful or they can be non-painful. So in men who have sex with men, examination is very important. In image A here, you can see a very subtle anal and perianal lesions. In B and C, rectal lesions are depicted. In D, there's more ulcerous appearing perianal lesions. And in E, F, and G, there's more typical perianal pustules. In H, you can see only a very subtle perianal ulcer. So here I'm highlighting some less typical rashes that are at least common enough that we've seen them here at MGH. In the top left, you can see that some patients present with more hemorrhagic appearing sort of deep-seated crusts. Some patients may even have frank bleeding into the skin, especially in regions with a high, heavy disease burden, actually causing purpura. Our colleagues in New York, which have seen cases of this, have described them as non-palpable. Here in the top middle, you can see a very subtle lesion on the hand that was PCR positive. The surrounding erythema is very hard to appreciate. In the top right is a good illustration that in darker skinned individuals, the erythema really may be entirely absent. The patient in the bottom left had a more diffuse maculopapular rash, in addition to 2 or 3 pustules that we really needed to go hunting for. And you can see how this could be very easily confused with secondary syphilis or a drug rash. In the bottom middle, you can see lesions in different stages of development, likely with that central lesion that began and has now crusted, and these secondary sort of satellite lesions, which probably occurred from auto-inoculation. In the bottom right here, you can maybe see a very subtle perianal lesion about at your 10 o'clock. And this really emphasizes that great care needs to be paid to body sites that could have darker skin or might be hairy. So in the current outbreak, with the case burden so focused in men who have sex with men, if you have a classic rash, the pretest probability of it being monkeypox is pretty high, and anywhere between 25 and 40% of patients that we've tested here at MGH have been PCR positive. But monkeypox has substantial clinical overlap with other rash-causing pathogens. Here in the top left, you can see primary varicella. This tends to be more pruritic than monkeypox and also helpfully lack the lymphadenopathy that we see very commonly. Herpes simplex may present similarly, both in the perioral and in the anogenital region. This is usually painful, but monkeypox may be painful as well. And at least primary herpes simplex infection can also cause lymphadenopathy. So in many cases, we are sending HSV PCR concurrently with monkeypox PCR. In the top right, you can see molluscum. Though it typically lacks the erythematous base of monkeypox, you can sometimes see erythema with molluscum dermatitis, which can be seen. Erica referred to suspected childhood cases of monkeypox that were not monkeypox. Here in the bottom left, you can see an example of a hand, foot, and mouth exanthem. Hand, foot, and mouth rashes are not usually pustular or painful, and systemic symptoms are less commonly present, but it can be easily confused. Here in the bottom right, you can see a patient with secondary syphilis. They certainly can have systemic symptoms, though lymphadenopathy is not common and the rash is not painful. Okay, so let me now present 3 illustrative cases from the Mass General. So in our first case, this is an otherwise healthy man in his 30s on pre-exposure prophylaxis for HIV. He presented to our emergency room with painful left inguinal lymphadenopathy. So 1 month prior to his presentation to us, following multiple sexual encounters with men, he experienced fevers, chills, and then developed multiple small lesions on his chest, arm, and calf, as well as some umbilicated perianal lesions. Testing was not widely available then. A clinical diagnosis of human monkeypox was made. He isolated, the lesions crusted, fell off, and his systemic symptoms improved. But approximately 3 weeks after his initial symptoms and 1 week after his initial systemic symptoms resolved, he again developed subjective fevers, and he had rapid development of 2 separate large painful lesions in the inguinal, left inguinal region, where he had previously had non-painful lymphadenopathy. So here's a picture of this. On physical exam, these lesions were tender, indurated, and fluctuant with overlying erythema. There was no spontaneous drainage, and he was otherwise well appearing. He had normal vital signs. A skin exam confirmed desquamation of his prior suspected monkeypox lesions, and we did not find any other genital ulcers. So he was admitted for further diagnostics and surgical evaluation. Surgery saw him, and aspiration of the 2 lesions yielded about 10 cc's of purulent liquid, which we sent for further testing. So cultures from the surgical aspiration grew strep pyogenes. We also sent monkeypox PCR from the pus, and PCR was positive for monkeypox as well. We also screened him for routine bacterial STIs, and his anorectal chlamydia nucleic acid amplification test was also positive. So given the rapid evolution of the abscesses and the growth of strep pyogenes from sterile sites, this is likely a presentation of a bacterial superinfection, that is streptococcal lymphadenitis. While we did PCR monkeypox from the lymph nodes, we suspect that this probably reflects residual DNA positivity in the setting of his prior infection. Interestingly, chlamydia was isolated from the rectum, which I think at the minimum illustrates the high degree of bacterial co-infection we're seeing in people with monkeypox. Though we think that the streptococcal superinfection is more likely the cause of his lymph node swelling, this syndrome could also be consistent with lymphogranuloma venereum, or LGV. This is a rare invasive syndrome caused by chlamydia. These patients most commonly have proctitis, but an inguinal syndrome like this can occur. So our second case. Our second case is an otherwise healthy man in his 20s who presented to our emergency department with a right thumb perinecia. 3 days prior to presentation, he described the development of a lesion of his right thumb cuticle that progressively became pustular, then painful, and then swollen. And he presented to us when he developed quickly tracking erythema up his arm. He had lab testing on admission, which were remarkable for a moderate transaminitis. He was seen in our ER by orthopedics and underwent bedside IND and was started on broad spectrum antibiotics. He was then admitted to the orthopedic service, but upon admission, he was appreciated to have 2 pustular lesions on his thigh, and over the next day, the evolution of more pustules on his torso and extremities. It was at that time that monkeypox was suspected and our team was called. So when our team interviewed him, he gave the additional history that he had sex with women, most recently 3 weeks prior to presentation. He also traveled for work and leisure and stayed in 3 different hotels or private residences over the prior 3 weekends. He did improve slowly on antibiotics. Orthopox virus PCR testing was sent and was positive. So our final diagnosis here was monkeypox perinecia, so-called monkeypox whitlow, with bacterial superinfection and lymphangitic spread. And he had additional lesions that popped up while he was in the hospital, either from autoinoculation or possibly a secondary viremia. We've also seen a couple of cases like this with elevated liver function tests. He may have also had a monkeypox hepatitis, perhaps concurrently with his viremia. So this case emphasizes the presentation of monkeypox whitlow, which is likely analogous to herpetic whitlow and has been reported in the literature. This man also lacked typical epidemiologic risk factors. So it's important, as Dr. Shenoy emphasized, to have a high clinical suspicion in patients with the development of disseminated papulopustular rash. Our third case, this is a man in his 30s with well-controlled HIV and a history of herpes simplex virus and chlamydia infection, who presented to our ED with 3 days of skin lesions in the pubic area and 1 to 2 days of fevers. He was sexually active with male partners last 6 days prior to the presentation, when he had oral sex with a partner who was apparently asymptomatic. He shaved his pubic area 4 days prior to presentation, and the next day noted the onset of scattered lesions on his pubis that was originally thought to be folliculitis. He monitored it, but the lesions subsequently became enlarged and umbilicated. In the day prior to presentation, he developed fevers to 102 Fahrenheit at home, so he presented to RED. In RED, he was afebrile, but was slightly ill-appearing and diaphoretic. He had no lymphadenopathy. We didn't appreciate any oropharyngeal or perianal lesions. And the skin exam was notable for greater than 20 of these umbilicated lesions on the penile shaft, scrotum, and the pubis in the area that he shaved. PCR was sent and returned positive. So the diagnosis that we made here was monkeypox infection, but probably initially just affecting a small amount of his pubic area, with subsequent widespread autoinoculation from shaving. His shaving may have resulted in skin microtrauma that increased his susceptibility to seeding. And this case again illustrates the dangers of autoinoculation. As I said, we're also currently following that case of conjunctivitis that likely also resulted from autoinoculation. Let me shift gears now. As Dr. Shenoy showed you, we may be seeing a decrease in cases here in the US. A large part of this decrease is probably due to changes in sexual behavior that were mentioned earlier. In a long-running internet survey that's a collaboration between Emory University in partnership with our CDC, participants who responded to the survey in 2021 were recontacted in August. And at that time, they reported changing their sexual behavior since learning of the monkeypox outbreak. About half reported reducing their number of sexual partners. Half reported reducing sex with semi-anonymous partners they met online. And 50% also reported reducing one-time sexual encounters in favor of more consistent sexual partners. The other factor that's likely bringing down cases is vaccination. As you can see here, from data from the CDC, vaccination in the US started slowly, but by late July, we were vaccinating more than 50,000 people in a week in the US. And we're likely past 500,000 vaccinations in the US as well by now. Like in Canada, due to vaccine shortages in many US jurisdictions, we had to restrict eligibility. As I'll talk more about, the vaccine that we're giving was approved as a 2-dose series, but in Massachusetts, like I understand is being done in many jurisdictions in Canada, we had been deferring second doses with the hope that partial vaccination could help stem the outbreak. However, though, like other places in the US, much of our vaccinees are now receiving their second doses. And in a bit, I'll tell you how we're achieving that. So unfortunately, as we see with many other health-related conditions in the US, we're seeing disturbing disparities by race. In the US, Americans identifying as white make up around 30% of cases at this point, but 50% of vaccinations. In contrast, Black Americans, though they make up 30% of cases, have received less than 15% of vaccinations. The CDC and the Massachusetts Department of Health are implementing multiple measures to try to ameliorate this. But it's a stark reminder that we have to design our healthcare systems to preempt this. So I'll review what our approach to vaccination has been here in Massachusetts. This is broadly similar to the eligibility requirements that I found online for Toronto and in Ottawa, for example, though their guidelines are a bit more expansive, at least for first doses. So the Commonwealth of Massachusetts has sent vaccine to 14 sites. Our sexual health clinic has delivered almost 3,500 vaccine doses. And currently, the majority of people are getting vaccine if they have had multiple sexual partners in the past 14 days. The vast majority of our vaccinees are men who have sex with men. Let me review the vaccine itself. So this is a modified Vaccinia ankara strain of Vaccinia called Jynneos. It's a third-generation smallpox vaccine. Specifically, it's a non-replicating derivative of the ACAM2000 Vaccinia strain. This is itself a derivative of the Dryvax vaccine that was used in the US as part of the worldwide smallpox eradication effort. The US maintains a stockpile of smallpox vaccine in the case of a accidental lab release or a bioweapon event. The majority of our stockpiles are ACAM2000, but because the morbidity and mortality of monkeypox has been low, ACAM2000 is not being used in the current outbreak. And this is because this is a replication competent virus that causes substantial side effects in a large minority of vaccinated patients. In immunocompromised patients, ACAM2000 has the potential to cause disseminated vaccinia disease, which can be life-threatening and which is likely not uncommon. And this is important since we are seeing a significant number of new HIV diagnoses, and some of these patients who would be eligible for Jynneos pre-exposure prophylaxis could have low CD4 counts. In contrast, Jynneos is safe to use in immunocompromised patients since it's not capable of replicating in human cells. Jynneos was attenuated by passaging more than 500 times in cultured chicken cells. The exact molecular mechanism leading to this reduced tropism is unknown. That is that it can replicate in chicken cells, but not human cells. But the virus itself has undergone significant genome loss compared to its ancestor, losing 10 to 20% of its genomic material with some other mutations. Jynneos itself, as I said, is grown on cultured chicken embryo fibroblast cells. And because of the culture conditions, each 0.5 ml dose may contain a small amount of chicken or egg protein, a tiny amount of gentamicin, and a very, very small amount of ciprofloxacin. Because of this, the only strict contraindication to Jynneos is anaphylaxis to Jynneos. Though precautions are recommended in people with anaphylaxis to chicken or egg protein that are avoiding chicken and egg protein, and anaphylaxis to gentamicin or cipro. But the CDC suggests that after a risk-benefit discussion, even people with anaphylaxis to cipro or gent can be given the vaccine and directly observed for 30 minutes. Jynneos was designed as a 2-dose regimen with dose 1 at day 0 and dose 2 at day 28. So as I've said, because of limited availability, many jurisdictions, including ours, were deferring second doses to prioritize first doses. And looking at the Ottawa and Toronto public health websites this morning, only people with moderate or severe immunocompromise appear eligible for a second dose. It seems that a referral letter from a healthcare provider or a proof of immunocompromising medication is really required to get a second dose. To help relieve some of the supply constraints here in the US, CDC has endorsed an alternative vaccination regimen. So the standard regimen is 0.5 mLs given subcutaneously. So this results in one vaccination being obtained from a single vial. You may be familiar with intradermal administration. This is how a PPD or tuberculin skin test is done. The default now at MGH and in many US jurisdictions is instead of 0.5 mL subcutaneously to inject 0.1 mLs intradermally. So this in practice allows us to turn a single dose vial into a 4 or 5 dose multi-dose vial. And this has allowed us to begin giving second doses, which I think is likely important since we might expect that antibody levels after one dose may be lower than after 2 doses or might be transient, especially considering that Jynneos was not designed as a monkeypox vaccine. It was designed as a smallpox vaccine. And we know that phylogenetically, monkeypox is just as divergent from smallpox as smallpox is from vaccinia. So many experts are more comfortable with this full 2-dose series. Importantly, the switch to intradermal was based on immunogenicity data from a 2015 study, which showed equivalent or even improved immunogenicity with the 0.1 mL intradermal vaccination. Patients who received the intradermal vaccination had less systemic reactogenicity, but I'll tell you more about local reactogenicity. Though intradermal dosing has not been extensively tested in patients who are immunocompromised, it's not expected that they should respond any worse to this than subcutaneous administration. So in Massachusetts, with the exception of patients who form keloid scars, everybody is receiving intradermal dosing. So as I said, though intradermal Jynneos may have less systemic reactogenicity, it has pronounced local reactogenicity. In a 2015 study, after dose 2, nearly 80% had greater than 3 centimeters of erythema or induration. So this is a lot. Remember that a positive PPD is only greater than 1.5 centimeters of induration. So in severe cases of this local reactogenicity, we're seeing induration, erythema, and pain can be marked and resemble bacterial superinfection. This was one patient from our sexual health clinic that submitted photos. So importantly, you can see 2 spots here. This patient underwent an initial aborted attempt. A wheal didn't form before successful administration. So here on the left at 20 hours, you can see the development of pronounced erythema. Just 8 hours later here in the second image, there's this wave of spreading erythema and some induration. Some of that erythema is even tracking more centripetally. But this rash and the induration resolved over the next day, and a week later, the rash had completely resolved. Let me talk very briefly about Techobiarymat. For some patients with confirmed or presumptive monkeypox, we're using this. This is a small molecule that's thought to block secondary viral envelope formation, and we think is probably active across all orthopox viruses. This is not FDA approved for treatment of human monkeypox. So we are administrating it here at Mass General as across the US on an expanded access IND. The paperwork burden initially was quite substantial, though recently it has lessened. We've treated more than 50 patients at MGH this way. Unfortunately, we're also seeing racial disparities in terms of Techobiarymat administration, likely because it is still not widely available. Thankfully, there's 2 randomized trials that are starting that should generate data to speak to the efficacy of Techobiarymat. There are many secondary endpoints, but both trials, one in the US and one in the UK, are planning to enroll 500 people with monkeypox, with the primary endpoint being time to resolution of active lesions. Having a widely available, efficacious, safe oral drug like Techobiarymat will be important for monkeypox, not just in the current outbreak, but hopefully for endemic monkeypox infection as well. So thank you so much for joining me and Dr. Shenoy for our talk. We're looking forward to questions and learning from the audience. For example, what features of the outbreak have been different in the US? How's your experience been like in Canada? What are some differences in infection prevention and control approaches? How have you managed exposure in healthcare facilities? Have you seen shifts in sexual behavior in your patients? And what's your impression of Canadian monkeypox vaccination and antiviral use? Let me stop sharing my screen.
Thank you very much for the presentations. Thanks, Dr. Lazarus. Thank you, Dr. Shenoy. And now I'll start to go through some of the questions for you. And so some of the questions from the Q&A include, where do you find monkeypox management fit within? Does it happen within sexual health clinics or within general or primary care settings? Where is most of your experience now coming from?
I can answer that. The answer is yes. Most of our current experience is being done either through our sexual health clinic. Many of the patients who are presenting are our own patients who we see here either for HIV treatment or as our primary care patients in our outpatient ID practice. Other patients we're encountering when we're consulted mostly by our emergency department, though we also have an extensive network of urgent care settings that are bringing in some patients. Our primary care providers have been given resources to recognize monkeypox, though it still is an out referral type illness.
Thank you. And could you tell us a bit about the severe cases and globally in terms of mortality and the complications that necessitated treatment with Techobiarymat and from your experience and other experience across the US?
Yeah, I can speak a little to that. So thankfully, we've had no deaths here at MGH and no one admitted to our ICU. Though we have had a couple of patients who were admitted because of the severity of some of the oropharyngeal or anorectal lesions. These can be really severe. And these are cases where we wanted to administer Techobiarymat. The CDC has guidelines that suggest consideration of Techobiarymat for facial and anogenital lesions as well. So here at MGH, we've been somewhat expansive in treating this. We've had, I think, 1 or 2 deaths reported in the US so far. I don't believe that those cases have been fully reported yet, though we're looking for more information. Certainly patients who are severely immunosuppressed, particularly for solid organ transplants or hematologic malignancy, they would be expected to have severe disseminated monkeypox disease. We would want to use Techobiarymat early for them.
Thank you. The next question is for Dr. Shenoy. In terms of your guidelines for healthcare workers that have suspected monkeypox, what have been your instructions in terms of isolation, staying away from work, etc.?
Well, we followed kind of the standard guidelines. And an individual a healthcare worker who presents with reports signs or symptoms, they would be managed the same way we would manage a patient in terms of they need to be isolated until they're declared based on a clinical evaluation that all the lesions have resolved and there's reepithelialization. And that is also the way we've done it in our system is there's a conversation between the clinician caring for that individual or occupational health services in the setting of an employee with our public health partners to make sure that we're all on the same page that that person can be released from isolation. We've had some interesting cases of prolonging isolation, not in healthcare workers. I'm just thinking about some of the patients that we've had with unusually prolonged isolation because of the aberrant infections. For example, we've had a patient with extensive skin lesions, facial lesions for long periods of time. It's taken a long time for those to heal. We've also had the reference case to conjunctivitis where it's not quite clear if there's active disease in the eye, other skin lesions have resolved, is this an area of active viral replication and potentially transmission? And those are conversations we have on a case-by-case basis with our public health colleagues to make sure that we kind of learn together and make the right decision around release from isolation.
Thank you. And the next question is also to you in terms of human to animal and animal reservoirs. What's the surveillance and the state of that in terms of companion animals and others?
Well, so we haven't had a case here where there's been a suspected human to animal, like at MGH, of transmission, although there was one reported to a pet dog, I think on the West Coast. There's guidance around this in two elements. One, if the individual, the human has monkeypox and they have pets in the home, how to manage those. Basically, it's not rocket science. It's you're not really supposed to be caring for the pet while you're infectious, but also if you suspect your pet has monkeypox, what you're supposed to do and what you're not supposed to do. The CDC has a really nice grid where they've looked at kind of basically all the possible animals out there and what we know and what we don't know about the ability of those animals to be infected. So we kind of track that and we provide some of that guidance to our patients who have pets in the home about how to limit the risk to the pet while they're still infectious. I don't know, Dr. Lazarus, if you have anything to add about the pets. We've talked about it, but that's where we are.
Excellent, thank you very much. And in terms of the clinical presentation and some of the differences between the current epidemic and prior descriptions, what are some of the key differences between cases that you're seeing in the US outbreak versus the previously reported since the 70s? And any evidence that links the inoculation site to the focus of the lesions?
Yeah, those are both really good questions. So, I mean, I think the main difference that we're seeing is that it seems to be less severe, thankfully. You know, though clade 2, that is sort of the former West African clade that we're dealing with here, was reported to have low mortality. You know, in some case series, it was less than 1% or less than 1%. And we have not seen that borne out in the US, which is a real blessing. So, you know, whether that is due to our healthcare system, I really don't think so. I think it's probably due to better case detection. So hopefully we're seeing the true mortality rate of this. A main difference is the distribution of the rash. You know, as opposed to what we were seeing typically with children in endemic regions, the rash can be only on one body site as opposed to widely disseminated. And obviously we're seeing much more dissemination in the anogenital region. The question about inoculation site is a really good one that I think we talk about a lot. You know, I think that in some cases we're seeing disease only at what we hypothesize is the inoculation site. Sometimes we see cases where we think there's a primary inoculation site and then secondary viremia. And then sometimes we see a primary inoculation site and secondary sites of autoinoculation. You know, the cases of rectal disease probably are associated with receptive anal intercourse. The same may be true with the sort of obvious oropharyngeal disease where we see pustules or plaques. Though clearly some of the cases of pharyngitis are sort of that more non-specific viral pharyngitis that we see with other diseases that cause viremia. I don't know. I look forward to figuring out.
Very good. And another question is, what is the proportion have you seen viral co-infections such as herpes family, as well as secondary bacterial infections in your overall experience?
Dr. Shenoy can jump in. I don't think we've seen any viral co-infections. I mean, besides HIV. We've certainly had cases where it turned out to not be monkeypox, but to be another viral process. Thankfully, the rate of bacterial co-infection, superinfection has been really low. I would say probably less than 2 or 3% of the cases that we've seen at MGH. We've seen a gratifying number of mostly uncomplicated cases. Fair amount of gonorrhea and chlamydia,
Thank you very much for the answers. We're reaching the end of our time, but I would like to ask if maybe you could comment on what do you think the proportion of asymptomatic versus symptomatic infection, any data because of the complexity of serology. And then another comment, if you could, about some scarring and what happens with the healing of the lesions that you described.
Maybe I'll start with start on the asymptomatic part. So this is a great question. I think we believe at this point that it's probably rare. We don't know the extent of if it is occurring, how much transmission can result from it. There is a well-known study from samples taken at an STI clinic in the UK, I think in May, where they 200 or so individuals tested for STIs, and they looked retrospectively and they found 3 of those with monkeypox, presumably asymptomatic. So there's that. I think it's also thought that there could be posse symptomatic. And you saw, if you look at the pictures and you hear about the cases that Dr. Lazarus presented, you could see whereby it might not be recognized. So I think we'll learn more, but at this point, I think we believe it to be rare. And then the open question is around transmission from asymptomatic cases. Dr. Lazarus, anything to add on that? And then the scarring part is a great question too.
Yeah, no. I mean, I think many of us have seen case series that have documented PCR positivity. I think the one that I remember seeing is, I think there was something from continental Europe about PCR positivity in anorectal samples that were done for other reasons. And, surprising minority of those people had PCR positivity. But as we've learned with COVID, it's not clear the correlation between PCR positivity and viral infectivity. And I think we're also not sure what percentage of monkeypox exposures result in monkeypox infection, and the degree and the length at which DNA sticks around. The case that I presented with the streptococcal lymphangitis is a good illustration of that. He had PCR positivity from the lymph node 4 weeks, 5 weeks after initial infection and after all of his skin lesions had resolved. The scarring question is a tough one. I guess I don't know if I've seen a real case series. I have an outpatient who has had some hyperpigmentation, and I know we had somebody at our hospital who, in the setting of extensive plaque-like ulceration, has some initial scarring, though we're not sure how that's going to look after a few months.
Thank you very much. I will wrap up with the last more speculative question. So you both alluded to plateauing, cautiously alluded to plateauing of the cases and maybe changes in behavior plus the effect of vaccination, but no one knows exactly which one and how much. Where will this, do you continue to see a plateauing and decreasing, and where do you see the vaccination campaign going after this plateaus?
Dr. Shenoy, do you want to use your crystal ball?
Oh, I've got it right here. Well, I think, this is all speculative, but it could be that with the change in behaviors, plus maybe an expansion of the vaccination criteria to a broader group of individuals who are still at risk, that we might be able to get to a point where I think it's hard to think that it will completely burn out, but that there may be some low level that is, still has to be on the differential, still has to be considered. But hopefully with that combination of expanded vaccine, some more awareness around the behavioral modifications, and then, obviously that there's an immunity that will be there based on natural infection, which we probably think is quite good. Plus the vaccination strategy, we can maintain this in check. But it may be that now this becomes part of the workup, very focused, at least at this point, in sexual health clinics. Dr. Lazarus?
No, nothing to add. We've seen rumors that we may see expansion to all men who have sex with men, or all men with HIV, markers of increased sexual risk, but stay tuned for that.
And I just think what to add to that point, I think the question is also, it has been confined to a particular epidemiological kind of group. It hasn't emerged from that. And I don't think it's how do we think about this? Like, if it was going to emerge out of that group and enter into other, like more broadly, that probably would have happened at the height of this outbreak. It didn't. That doesn't mean it won't happen. And it just means that we all have to be kind of attuned to this and just understand the risks and know the presenting signs and symptoms to have that awareness to pick up those cases should they emerge as well.
Thank you very much, Dr. Shinoy and Dr. Lazarus, for engaging conversation and for being patient for all the questions. And the webinar will be available. The recording from today's webinar will be shortly available at the NCCID website under the webcast tab. Fill in the short evaluation, which you will receive shortly. It's really important for us when we plan the next activities. Thank you again very much for being with us today.
Thanks for having us. Bye-bye.